Good afternoon, everybody. Thank you for joining us today. My name's Caroline O'Dwyer. I work over in Barnet, and I'm very fortunate to be working alongside Cancer Alliance to try and find a way to work better with practices to help provide better cancer care for our patients. Lots of work being done this year, lots of resources being offered out, and hopefully tangible, helpful information. So today, we are going to talk about the FIT testing and FIT and why we do it, what's the benefits and how we can do it better. We're going to look at coding. We've got some team here from the Cancer Alliance. Now, we will record this webinar so that it can go out to the wider bit. So I don't know if you want to press record now, Amelia, or whoever's recording. Anybody with any objections, now's the time to say. Muna, I'm going to say you're on hold. There we go. So we've got our Cancer Alliance team here. I'm not sure if everybody's here, but I'm going to read their names out. They are. Maybe you could just give a wave. So we've got Amelia from our Cancer Alliance team. There we go. There's Amelia. We've got Dr. James Harris. There he is. He's got a wave. And Seema Chowdhury. I don't know if Dr. Chowdhury's on here just yet. She was jumping from a clinic over, but she'll join us and they're all going to be able to address you as the session takes place. It's an interactive session. If you would put your cameras on and we could get to see your faces, it'd be really nice. We'd like to hear from you. There's a few topics being covered, so please put your hand up and interrupt. You don't have to wait to the end. We don't want you to lose the thread. If you've got questions, it would be really helpful if you talk to us about it. So in this session, we're going to talk about FIT. The last session we did, we talked about some coding, and we are going to just recap on that just to make sure you've got the coding, any coding errors. It's just a little bit of housekeeping. So we'll do a recap on that. And we're going to be looking at FIT, why it's necessary, what's the benefit of it. Also want to give you a shout out for a date for your diaries. There is a clinical session planned for a webinar on the 15th of November. So you might want to make a note and put that in your leads, your clinical leads diaries or your cancer leads diaries, or indeed any of the team would be welcome, clinicians, to come along to that. You should have the information, but if you need it, just put it in the chat and we'll be able to send the links over to you.
Caroline, can I just say, it's hi.
I didn't know you were coming.
No, I can't stay for the whole event. I'm really sorry because I have something else that I'm speaking at. But I wanted to say thanks very much for setting up the sessions and running them, and thanks to all of you for joining in this kind of regular. Essentially kind of creating a kind of community of practice going forward with all our practice managers and the support staff within our practices, because I think with that together we can make real improvements in the delivery of our cancer care across NCL. So thank you very much. Thanks very much, Caroline, for leading the session today. Thank you.
Yeah, thank you. I didn't know Claire was coming, so I was standing in trying to pull it together, but Claire put it very, very succinctly. So the whole point of this is to get our practice managers across NCL all together at one forum and to hear it straight from Cancer Alliance, how we're doing, what can we do better, and it all impacts on our patients' care, and that's what we all want to do. So I'm probably better known in Barnet, but it's really nice to start working with the NCL forum and share sort of, you might have best practice, you might be doing better. So please make it an interactive session. Don't be shy, put your hands up, speak up, and let's have a conversation about how we can do things better. I'll hand over to Amelia and we'll start.
Brilliant. Yes, thank you for that. I'll just get the slides up for the session. Hopefully you should be able to see these.
Yeah, we can see.
Yeah, excellent. Yes, thank you. It's great to see so many of you here. So yeah, thank you for making the time to join this. I'm Amelia Robson. I'm a senior project manager in the primary care team in North Central London Cancer Alliance. And for some of my work, I've been looking at things like referral pathways, particularly FIT, but also other priority pathways, areas of improvement for our work around kind of the QOF, and also just generally looking at how we can support practices better in terms of, if there's any resources for things like supporting locums or, trying to sort of create some guidance for some of your areas of work. As a whole, the North Central London Cancer Alliance basically brings together patients, hospital trusts, GPs, health service commissioners and local authorities, and we're looking at improving cancer outcomes and care. We work across the boroughs of Barnet, Camden, Enfield, Haringey and Islington. As I mentioned, I'm from the primary care team. We do also have other teams working on areas such as screening, also acute diagnostics and treatment, and a variety of kind of pathway work. So I've included in these slides, which will be shared, a table with just some key contacts and who we are as a team. If you do have any questions between any of these webinars, I'd just like to say, the door's open if you have any questions or you want to get in touch. We're very receptive to all of that. And I just wanted to move on for a bit of a recap on what FIT is, which is the area of kind of priority in this webinar. So that's one of my focuses in terms of pathway improvement and improving referral practice. And some of you might have seen this already, but I think this is just for the benefit of others that might be less familiar. But basically, the fecal immunochemical test is basically a test for blood in poo, and it produces a score based on the patient's sample. And for symptomatic patients, basically, if you've got a negative FIT result, a normal exam and a normal full blood count, your risk is 0.1%, which is actually lower than the general population in terms of your cancer risk. So we can see that it's a really useful kind of risk stratification tool, and it's really helpful in terms of working to kind of prioritise cancers patients that are higher risk and work out which patients are those lower risk patients. And because of that, clinicians basically should be using FIT tests to inform the referral pathway of all patients under lower GI. So the crucial part of that is that the test should be done ahead of referral to help with that decision on the pathway that the patient should be taken on. And as part of that involves it to be used kind of clinically correctly, but also as a practice working on, making sure it's kind of coded if those tests are being carried out. And in NCL, this has been an area of focus because historically we've had some challenges in terms of uptake on FIT. And we've kind of consistently been below the national target for FIT usage, which is 80%. It's worth saying we have seen an improvement, over the last probably year or so on FIT, but I think it's worth, we do still have quite a lot to do on this area in order to meet the national target, and we've all got kind of room for improvement on that. And just to emphasise some of the reasons why FIT's important, is it basically will help us to ensure in practices we're risk stratifying patients. It has a role in following the NG12 guidance for lower GI, and also improves system capacity by making sure that patients aren't having kind of unnecessary colonoscopies and reducing that. And in turn, that helps kind of patient experience because patients aren't receiving unnecessary colonoscopies. It also means that high risk patients have that capacity protected for them. And this is part of supporting us to make the best use of capacity and reach some of our early diagnosis goals. So I think this is just a really important area to focus on. I just wanted to share as well, I will include a few links at the end of this intro, just to various resources. But one thing I wanted to mention is FIT generally varies a bit by practice in terms of uptake and use of that. And also by borough. If you want to see your practice data and you're not aware of your practice data, there is actually a PCN dashboard, which I'll share a link to, which allows you to kind of look up your percentage of lower GI referrals accompanied by a FIT test result. So I'll share the link to that in the chat. And it's worth saying that Haringey and Islington are actually two boroughs that do have some of the lowest FIT uptake, so are probably what we've been looking at a bit more. But actually all boroughs have room for improvement in terms of meeting the national target. So I think it's just something that collectively we can all kind of look at. And so I'll share those links in the chat now. But I wanted to hand over to Caroline, who's just going to give a recap on some of the code matching work that has been presented at a previous forum, but I think it's just worth kind of showing again for anyone that wasn't at that session.
Thanks, Amelia. Just a couple of things in the chat. So we've got a lovely comment here from Dr. Claire Stevens. I didn't know she was attending today, so I didn't really introduce her, but she's put in words of thanks and appreciation here in the chat. So just to let you know that she was online, I'm not sure she's going to be here for the duration. Amelia very kindly put in a link earlier for registering for our Practice Managers Forum. It's quite straightforward. You put the information on. It's very important for us to know who's attending so that we can give out information, disseminate stuff. Also, make sure that all of the communication we're doing is reaching all 5 boroughs. And it will be quite obvious if we're sitting there and the whole of Barnet hasn't attended, it means it didn't reach there. So it'd be really helpful if you could just add that on. If you've done it before and attended here before, you don't need to redo it. It's only for those people to go on the mailing list. Kat, I can see your hands up. Would you like to jump in?
It's about fit testing coding. So I don't know if you're going to cover it or if I should just jump in.
All right, hold tight. Let me do a bit, and
sure.
then if you then ask the question after.
Okay, thanks,
right?
Caroline. Sure.
No problem. And Amelia, please put in the link for the dashboard, which is always interesting to see where we are and see how we're performing against other people. So just a quick one on the recap. We did it at the earlier bit, but this is about when you're doing fit testing and the fit tests come back. It's making sure that these fit tests are attached and mapped correctly. Because you could be having information coming back, and if they're not mapped and not coded correctly, they won't be showing in your data. So this is what we're just going to go. It's a really short guide, just to remind people. So we go to next slide. Okay, so basically, if you look to the right-hand side, you're in Workflow Manager. You're going to go into the little cog or the configuration in Workflow Manager, and then you're going to go down and select the option in the organisation options, which says inbound code matches. We've all used this for all sorts of things, but this is particularly for the fit testing. You'll see on the right-hand side, it comes up with some of the terms that the lab use to be matched to a SNOMED. Look for them. So these are the three things that you're looking for: the quantitative fecal IT, or the quantitative fecal, can't pronounce it, test. And then you've got the fecal immunochemical test. So these are usually the 3 that you want to search for individually. Search for the first one, then search for the second one. So if you find the first one, you're going to go in and then you're going to edit it and assign the correct SNOMED code. Because this is what the test should be. You see, look at number 1, work view. Number 2, inbound codes. Number 3, have the test coming up. And number 4, that is the actual test that we're looking for. And you're going to look for these variations. You're going to edit and you're going to assign the SNOMED code. If you go to do these and nothing comes up under these 3 headings, it's likely that you've already done the matching. You might recall that when we were doing the IIF a couple of years ago, all the fit testing was coming back, or a lot of it was coming back incorrectly coded. And we couldn't understand why our figures weren't going right. So we worked with the lab, and a lot of people have this fixed, but I want to make sure, or we would like to make sure, that everybody is aware that this is properly mapped coming in. So these slides will go out, we'll have the instructions, and anybody who's a little bit stuck can jump in and ask some questions. You might be familiar with this, but this is how you access it. This is how you map your fit testing correctly. Once you've done it once, it will recognise that coming in every time. Does that make sense? Has anybody got any questions on that particular part? Well, I know questions. Kat, did that answer your questions, or did you want to ask something different?
It's something different. Apologies. I've got my camera, but it's positioned for my standing desk. So when I sit down and rest my legs, all you see is my forehead. So it's about I know there are codes to say if the fit test isn't appropriate for the referral, for a lower GI referral. We've had instances where the GP has said, I want to do a fit test, but I'm going to refer this patient anyway, regardless of the result of the fit test. And I don't want to delay the referral by waiting for the fit test. And obviously that's kind of put that patient out of sync for the 21 days before referral. Is there any coding that we can use there, or is there any sort of get out clause there?
I'll leave that to the clinicians to answer. I asked that question a while ago as well, Kat, so you're not alone.
Okay.
Claire, are you on here?
I think we might have Seymour. Do we have Seymour on the call now?
Yeah,
I'm
here.
But
I don't know whether we want to do questions at the end or as we go through. But yeah,
maybe as we go through, we can try.
Yeah. So I guess I think the first step is sort of finding out the reason why the clinician wants to send the referral right then and there. If the patient has an anal mass, rectal mass, or an anal ulceration, the patient does not need a FIT test, and they should be directly referred on a suspected lower GI cancer referral. If they don't have any of those 3 exclusion criteria, but they are presenting with potentially bowel cancer-related symptoms, then the guidance is that you should be doing a FIT test and using that to guide referral. If the patient declines a FIT test, then that's something different, and there is a code for that. But yeah, I hope that helps to clarify the query.
Sorry, it doesn't fully answer the query in this case. So these are not patients who it's not appropriate for. So, for example, you mentioned the anal mass. Nor patient has declined it, but patients who, and we know the codes for those, but patients who the doctor doesn't want to delay the referral, the FIT result isn't going to make an impact on the referral. They know they're going to refer regardless of the result.
Okay.
And they don't want to delay it, essentially.
So I think the thing is that what is it that makes them feel that they need to refer straight away? Okay. And that is a clinical decision. I think that's on a case-by-case basis. Yeah, the only kind of exclusion criteria for a FIT test is having an anal mass, rectal mass, or anal ulceration, or a patient declining a FIT test. All others should really be having a FIT test. There isn't any other code that I'm aware of that will kind of will help in this situation where they do need a FIT test, but they still want to do a referral right then and there. So yeah, I think it's difficult to understand without knowing the case-by-case situation.
Sorry, can I come in really quickly? So I've just had to switch to a different computer phone to be able to talk. Just to say, Catherine, it's the reason we need the FIT test is really for the secondary care to be able to decide what's appropriate in terms of, whether the patient needs a colonoscopy or not. And so because it's needed for resources, it's really important that we have a FIT test apart from those exclusions. The FIT test, if it was less than 10, but the patient still had what we call the sort of red flag, symptoms, the NG12, then it may be that they go on a different pathway, which is the FIT less than 10 pathway. So really, apart from those exclusions or a patient declining, it is essential that there is a FIT test attached because, and I think if there's any other concerns, then they probably ought to do an advice and guidance or try and contact the colorectal team to do that. It would really be very rare cases that they should be making a decision, without the FIT test, and secondary care do need them. So I don't know if that helps. I don't know if it's because of lateness and maybe them needing to make a decision before they leave. That's different. But even there, we would say they need to follow, send a task so that a clinician that's regularly there can follow it up and chase up that FIT test.
Yeah,
and do the form after. But yeah, we really want to discourage otherwise any referrals coming through otherwise apart from the exclusion criteria or a patient declining.
That actually just reminds me that if it is that the clinician is worried that if they do a FIT test but that someone get lost in the system without having their referral, we're actually going to go through a safety netting procedure for FIT test results later on, and that might actually help with some of your clinicians' fears if they're worried about patients getting lost.
Yeah, thank you. I'll pass it on to the clinicians. We are safety netting our fit tests now. Started a couple of months ago, so that's definitely helping anyway.
Great.
Thanks, Kat. I think Claire wanted to come in.
Just really quickly, and then I'm sorry I have to leave, but Catherine, one of the things that people may not be aware of is because the approach to FIT has changed and developed since the technology became available. But NHS England is very, very clear that the FIT test needs to be regarded as an investigation that happens at the beginning of the diagnostic pathway for appropriate patients. And so it's important for all the reasons that you've heard already that we have the FIT test, but it's NHS England's view is it's something that happens in primary care in a way that allows the primary care clinician to use the result to better prioritise and stratify where that patient needs to go onward. It's not something that they don't need to use the result of. So it's something that it's a test that needs to be done in primary care, and it's a test result that needs to be acted on in primary care, because depending on what that result shows will help the clinician choose the right current pathway. In the past, it was a little bit different, but not anymore. So that's the really important thing that clinicians. So when you're talking to your clinicians, it may be that people remember what they first heard about FIT a couple of years ago as opposed to what NHS England's view is now. Does that make sense?
Yeah, thank you, everyone. Thanks, Claire.
Thank you.
Okay, I apologise. For some reason I lost the slides, so I may have rushed through that. But I know within the slides there's step-by-step guide. I think it's about 10 or 10 steps. So we will send those out so that you can check your coding to make sure they're accurate. So I do apologise if it got a bit rushed through, but I'm just trying to remember it. I'm not sure why I can't see the slides, but everyone else can. It looks like Georgette understood because she's already had a check and she couldn't see anything. So well done, Georgette, for having a go. We'll move on if everybody's ready. Yep,
Okay,
next slide.
Yeah, so the next section we've got is onto CIMA, discussing some information for practices and setting up protocols to support staff.
Okay. Hi everyone. So yeah, like we just mentioned, we are just going to be going through some electronic safety netting. So it's the same kind of template that's used in safety netting your suspected cancer referrals, but it also allows you to safety net for tests, including FIT test results. I think that's coming up in the next few slides, so I'll just go through the rest of the slide first. The other thing that is also really useful is when clinicians are requesting FIT tests, they can set up an AccuRx text message reminder. And so they just need to type into the box FIT, and then you'll see the message pop up. And there will be one text that's sent then and there to the patient as a reminder. And then another one that goes out a few days later, again, as a reminder for the patient to complete and return that FIT test to your practice. And there's in the appendix of this presentation, there's a sort of a photo of how you can do this, but it's quite simple.
Would you like to go on to the
slides
on safety netting? Yeah.
Yeah. So I'm just wondering whether maybe I should share my screen to instead of going through this, but I guess this can all be handed out to everyone who's here, but I'll just share my screen for the moment so that okay. Can everyone see my screen? Yeah, great. Okay. So when trying to safety net for FIT test results, you'll probably have the consultation window already open. Click Run Template. And then click Safety Netting Template. I have this already here But if you don't already have this popping up in your recently used list, you could always just type and then search for that and it will come up. And then here you'll recognize this is the page that you use to safety net your suspected cancer referrals. We're going on to a different page here. On the left, you'll see direct access diagnostics. And then scroll down a bit on the page. Oops. Click this box here, referred for quantitative fecal immunochemical test. And this box is free text, so you can type whatever you want, but I normally type something like check fit test result back, and then you can decide what date you want to check this on. So I normally do something like a week, and then click save. And then click, so once you've completed your consultation notes, click save again. And that will save to notes. That box is just popping up because this is a dummy patient. Admin, I suppose every practice's admin will run searches to look for the safety netting alerts, and this will be included in that. And obviously they can let you know that this alert has come up, and you can have a look, and the clinician can have a look to see whether the test result is back. And if it's not back, that's probably a sort of a sign that you might need to recontact the patient to get them to make sure that they hand in the FIT test sample. Right. I'll stop sharing my screen now. And yeah, any questions about that? You can probably just run through the next few slides, because I think the next few slides were just images of how this pathway works. Okay, great. Obviously this is London, and there are a lot of patients who don't speak English as a first language. Completing the FIT test can be a little bit difficult for some people. You know, they might not have seen anything like this before. So, and that's even for the patients who do speak English. There are patient information leaflets in English and in a variety of foreign languages. And there's also a video in English and in multiple foreign languages as well. And these are available through these links here. Each practice could set up sort of an AccurRx that everyone in the practice can access, and to paste those links into the message, so that when giving out these FIT tests for patients to complete, you can also just ping them off a message with the leaflet or the video in. I think it's particularly useful to have it in English, as the majority will be able to read and understand the video in English, and you may want to keep the web address of the translations somewhere on your computer, or in perhaps the ENIS homepage, if that's helpful. So next slide. Okay, so FIT tests are done in a very specific bottle. That is a green bottle, green topped bottle. It's quite small, it's smaller than a few of the other stool test bottles. So it's really important that we make sure that we give patients the right bottle to do the sample in. Otherwise, the sample is going to be rejected by the lab. So this is a useful poster for you to have out in reception for your admin staff to have a look at. It's got a picture of the FIT test bottle there, and it's just a reminder that the bottle needs to be labelled with the patient's name and date of birth. A reminder to give them a patient information leaflet, or the video, as we discussed in the previous slide. Return it to the practice within a short time frame, and then safety net that fit test has fit test result. So that safety netting could be done by the clinician or could be done by admin or reception who are giving out that fit test sample bottle. And I think this is that post is going to go out in the resources as well. So just a slightly bigger picture, just to emphasize that this middle bottle with a green top is the bottle that should be given to patients. This is with the container is open. This is how the sort of stick looks like on the inside. And these two bottles are used for some fecal samples, but definitely not fit tests. This is the green tops bottle is the only one used for fit tests. Next slide, please. Okay, so over the next few slides, we're just going to go over ways to help support clinicians and in particular locums in practices. So I think that some clinicians they are worried that if they hand patients a fit test bottle and request that the patient may not do the sample, they won't return it, and that they may need a suspected cancer referral, but because they don't return the test, they therefore won't be referred. So the safety netting process that I explained through earlier will help to kind of prevent that from happening. But it's important that if it is a locum who is requesting that test, to make sure that they follow the same safety netting processes that have been set up in the practice, and just making sure that you have a system in place for those results that come back. So who is going to action those results? Is it going to be the usual GP? Is it going to be one of the partners? Is it going to be someone else? So that's something that each practice will probably have to just individually decide. You may already have a setup already. And just the question for you also, is there any kind of support that you think you need to ensure the process for ordering a fit test and reviewing the results? Do you have any questions about what we discussed over the last few slides? Okay. Okay, so we can go to the next slide. So just really a summary of what we can do to help support clinicians and in particular locums. There's a handout coming up, I think, in the next slide, actually, on the sort of correct way to practice and ordering fit test results. Perhaps this could be left in the clinic rooms or in a sort of a handbook for locums. Individual practices will decide on how the results that are requested by locums are actioned, and I suppose that probably goes for all results, not just fit tests. Then continuing education for locums on the correct use of fit. So just making sure that we as clinicians and in particular locums don't refer a patient without a fit test unless that patient has a rectal mass, anal mass, or anal ulceration, or unless there's any other reason why that patient can't or shouldn't do a fit test. So we'll be sharing materials on safety netting. So all of the things that we've gone through today, the electronic safety netting, the text messages, and the handout that's coming up later will be shared with you. And the other thing as practice managers is just making sure that the clinicians are following the guidance where appropriate. Auditing the referrals can sometimes help as well, just seeing what's actually happened if you're finding that a lot of referrals are being sent without fit test results. Thanks. Next slide. So this is a useful sort of flow chart that I think all clinicians will actually find useful, but it's got at the top supporting locum. So a patient will present to the GP with possible bowel cancer related symptoms. We've just called those NG12 symptoms as the NICE guidelines refer to them within the NG12 guidance. As a clinician, you'll check with the patient whether they've had a rectal mass, anal mass, or anal ulceration. If they do, they're going to be referred directly onto the suspected lower GI cancer pathway. If they don't have any of those three things, then the next step would be to order a FIT test, then making sure you put in the electronic safety netting, and then the practice admin or reception to run the regular searches for the safety netting dates. And once the FIT test result comes back, so that is to be actioned by the clinician who's reviewing the result or who's been allocated to action that result. Great. Any questions so far? Okay, thank you. Next slide.
The next slide is actually the sort of whether anyone has any questions on the content. I can see we've got one in the chat, which you might want to have a look at.
Yeah, I think I was going to just jump in here just to bring the questions forward to people's minds. So I just wanted to summarise as a practice manager what I believe I've heard today, just to make sure that we're sort of clear with our messaging. So today's session was about FIT. So they told us why FIT is important and why we need to do it. So my understanding is the FIT testing actually determines where the pathway of where they're going to be referred. So it's important that they accompany it. We looked at coding, just in case you're sending out FIT tests and you're not getting recorded, correctly coded, so that we wouldn't know that you're getting results in. What's important, I think, Kat brought it up, that some clinicians are referring and not waiting for the FIT testings, which I think Seema and I can't remember who else was talking, actually made it very clear that that's not the correct way of doing it. We should wait, we should accompany it. And I can understand how that might be a little bit of carrying a bit of risk and worrying that you'll forget something. So then they followed up with a very comprehensive safety netting system, which I would imagine you could adopt for more than just the FIT testing, by getting people used to doing the template and getting an admin team set up to run these searches and just double check everything's coming through. I quite like the idea of the safety netting, that a lot of the resources can be attached to Accurex and you can send this information out to your patients to remind them and give them simple, straightforward instructions on how to do the test, which I think is really important. What was very interesting was the bottles. I mean, how many times do people come in and ask receptionists, are they giving out the wrong bottles? And I thought that'd be quite nice. Your next receptionist meetings, put a few bottles up and do the bottle challenge and see who can tell you which bottle is from which test. Would be quite a nice thing. Just ideas that you might want to bring into your practice to make this familiar and eliminate sort of those type of mistakes, and then people having to repeat a test, which isn't the nicest one to do, is it really? And then, of course, the problem is we get our practices right, we get our clinicians right, and then we have our locums or our registrars or our medical students or F2s come in, and we have these lovely induction packs, and this would form part of it and part of their induction. And I think there's also a little bit of work here for the practices, that if you're using a regular locum, that you're checking that they are following your guidance. If you have a one-off session, I'm quite sure you have a system in place that a clinician oversees and has a quick look to make sure that they've done things appropriately, because that would be your risk management to double check. So if there was a test done and they haven't coded it, they could pick up on it. So regular locums, you would bring them in with part of it. And I think that's what Kat brought up. You know, as much as we have these lovely guidance and we have things, how do we get them to follow it? And that's what my answer would be. We have our team. If you're having a one-off locum, there should be a clinician that's going to check their consultations, just to double check, just skim over. If it's a regular locum, you have to work with them to say this is part of it. And again, do some checks and then have to address it. And if these are regular locums working in NCL, they should be familiar with these guidance and they should be familiar with the processes. It's if we can set them all up in each practice in a similar way, it makes life easier for the practice, but also for the locums, because they know this is what's expected of them. Is that helpful? That would be my summary of the session. Is that what everybody believed they heard today? Silence is not going to help. You have to speak. Somebody has to say yes or no. You have to start picking at your cat.
Nicely summarised, Caroline.
Thank you. There's lots of names on here that I don't know, but I'd really like to hear from them to say, is there any questions that you have or anything that you'd like to ask that wasn't clear?
No questions, thank you.
Thank you. That's really good of you. Okay, so if there's no questions, what's next we've got to do? We've got to share out some information and share out contact details. These slides will go out, and there will be a place, for resources. You can contact, any of the managers can contact me, but Amelia's going to give out contact lists of everybody if you need anything.
Yeah, we'll send the slides which have some of those setup guides, and we'll also send round that poster which Seema showed on the Fit admin guide. So yeah, you'll all have that, and also like any of the links that we've presented. Yeah, and I would also say, if any of you have a moment, we're going to also share a link to just a quick survey to get some feedback on some of these sessions, because obviously we'll be looking to develop, how we support practices on a range of different areas across the DES and QOF. So your feedback's like really welcome for some of the next steps of that journey.
Yeah, I think it's important to share these workshops. Will be a continuation. So the next one that we plan, we might skim over something, but we'll be bringing new information. So it's going to be sort of onwards and how we develop. And if you come away from the sessions and do what we've asked and implement the safety netting and check your coding, that's one part of that. And have a look at your internal processes for managing fit. When we move on to the next part of it, that's already covered. So we're trying to do it as a work in progress for everybody to come on board and give you the tools and small bits rather than just send everything out in one go. Yep, so that's the survey there Amelia's just posted in the chat. If you wouldn't mind just filling that in, that'd be helpful. Okay, anything else, Amelia?
Oh, I think that's it. Yeah, thank you, everyone.
Okay, do you want to just show the contact slide so people can see the names of everybody so they're familiar? Because there's clinical and non-clinical leads on there that people might want to contact depending on what issues they've got or things they want to discuss. There we go. Quite a team. Some of those names you might know. I've worked with ECTA before, and that's in the prevention and stuff. So we will cross over. You might recognise some of the names already, but these are the people that we will be working with to try and improve things. It was Irina who spoke. Sorry, I missed that. Who spoke about the need for doing the fit testing before you do the referral. Irina and Seema, that was it. Okay. If there's nothing else, I think we could close, give you back 13 minutes of your time. I'm sure you can go get yourself a cup of coffee and digest it all. Please don't walk away and forget about it. Think about your fit testing. It doesn't take long. What you're being asked to do is just to check what you're doing, maybe change a few things. If you're doing your own safety netting, maybe think about the electronic one, because it'll take less time. It's a good system. It's being tried out. So maybe just spend a little bit of time and focus on this fit testing, so you're ready then as we move on and start on the sort of working with Cancer Alliance to improve the care for patients. Lovely to see you all. Thank you to everyone for attending and those presenting and sharing information. And we'll see you again soon.